Welcome to this presentation concerning how social workers might recognize and address stigma related to substance misuse and how this issue relates to recovery. It's an important topic for everyone who cares about addressing substance misuse and supporting recovery. Developing this presentation was one commitment in the 2019 expansion of Practitioner Education grant awarded to Council on Social Work Education from the Substance Abuse and Mental Health Services Administration. During the 2-year project, CSWE is implementing a high-quality, standardized substance use disorder curriculum to strengthen preparation of future social work practitioners to deliver effective, evidence-based substance use disorder prevention, treatment, and recovery services. So let's get started. Junkie, stoner, pothead, crackhead, tweaker. What images do these words bring to mind? What opinions do you have about a person described this way? You may never use these labels personally or professionally, but how about addict, alcoholic, drug abuser, user, drug seeker? You may have been more likely to use these labels. This presentation encourages you to say goodbye to these labels and learn some constructive ways to address substance-related stigma in your own work and communities. This is an outline of the topics presented. We'll talk about labels and stigma, including how family members experience members' experiences related to a person's substance misuse, and will identify strategies for making a difference in addressing substance-related stigma. The words we use convey meaning. They communicate attitudes, beliefs, understanding, misconceptions, biases, stereotypes, history, and customs. Several research studies experimentally compared perceptions formed by describing a person as having a substance use disorder versus being a substance abuser. The results consistently demonstrated that the substance abuser description leads to viewing a person as being a greater threat to society, more blameworthy, less likely to benefit from treatment, more likely to benefit from moral rather than medical intervention, and more likely to benefit from punishment or being deserving of punishment, punitive measures, such as being given a jail sentence as a wake-up call. The conclusion is clear. It matters very much how we refer to individuals engaged in substance misuse and experiencing substance use disorders. According to the website called Broken No More, a worthwhile goal is to use substance misuse-related language with great care. One problem with labeling someone as an addict or alcoholic, substance abuser, or other stigmatizing terms is that labels tend to melt away a person's uniqueness and individuality. The label becomes who the person is, rather than describing one aspect of what makes up a complex individual. Labels depersonalize. When we apply these labels, the person becomes categorized that way. It becomes their identity. We ignore the rest of who that person is. The second problem with labeling is that we make assumptions about a person based on the category to which they've been assigned. For example, when we assign someone to a labeled category, we expect them to stay put. We impose assumptions about the likelihood that they can ever really change. So once labeled an addict, alcoholic, substance abuser, or with some other substance-related term, we expect that they will always fit that label, regardless of situation and regardless of any changes they do accomplish. At best, maybe they can become an ex-addict or a former addict, but they remain identified with substance misuse or addiction being their central defining trait. Put another way, we assume that leopards don't change their spots. This reflects a rather hopeless and inaccurate point of view. There exists plenty of evidence that people do change and recovery does happen. Sometimes the language we use about substance misuse implies that a person is to blame for causing their own problems and for problems they may have caused others. The result of blame is shame and blame, and blame calls for punishment. This is a far cry from helping a person assume responsibility for engaging in addictive behaviors and making healthful changes in their lives. Yet another problem with labeling a person is that it creates a social and psychological distance. Distancing meant to make the person applying the labels more comfortable. Labels separate us and emphasize our differences rather than how we are alike. Intentional or unintentional messages conveyed through labels categorize the labeled person as separate from others and from ourselves. Labeling people establishes a them versus us mentality. It emphasizes how those people are different from us and how they are not like me. Not like me is at the very root of stigma. What exactly is stigma? These are some dictionary definitions. Stigma comes in different forms. It may originate from the general community in which a person functions, from professionals with whom a person might interact, and from within, as self-stigma. A person's experiences and behaviors may be affected by both actual and perceived stigma. They also may be influenced by anticipation of encountering stigma. Here's a more detailed definition of stigma, indicating that stigma occurs at all levels of society, from macro-level social policy systems and institutions to communities, families, and individuals. This definition also addresses implications. Stigma manifests in our behavior, social structures, policy, and other discriminatory practices, what we call explicit bias. Explicit bias might be expressed in terms of rules, policies, and procedures concerning substance misuse. Such explicit bias impacts many aspects of life for individuals experiencing substance use disorders. For example, it may impact housing and food security, employment and income stability, social and healthcare services, and entanglement with criminal justice, child welfare, and legal systems. Implicit bias, on the other hand, is about underlying, even subconscious beliefs and attitudes. These beliefs and attitudes may influence our behavior in unintended ways, ways that interfere with our social interactions and engaging with each other. In terms of clinical practice, implicit bias impedes the formation of therapeutic alliance, the working relationship. Words like addict, alcoholic, and substance abuser should no longer be used in professional or lay settings because of the implicit bias such terms evoke both in ourselves and in others. The sociologist Erving Goffman described the stigma experience as turning a whole and usual person into a tainted and discounted one. Through repeated experiences of stigma, a person develops what Goffman called a spoiled identity, where someone feels tainted and experiences a wholesale rejection of their identity. Stigma marginalizes members of a population. These individuals become systematically excluded, discounted, less enfranchised in society, and categorized as less desirable beings. In some cases, they're rendered invisible. The inherent dignity of of a person is lost. Loss of self-respect and believing yourself unworthy can result in the "why try" phenomenon as it relates to seeking help or otherwise engaging in recovery efforts. Simply anticipating that stigma will be encountered in future interactions inhibits a person's willingness to risk the stress of yet another anticipated stigma experience. Evidence indicates that individuals experiencing substance use disorders encounter a remarkably high number of stigmatizing experiences, and these experiences may act as personal and systematic barriers for help seeking and for the recovery process. In a 2000-2001 study comparing stigma related to 18 health or social conditions conducted across 16 nations, drug addiction was associated with the highest levels of disapproval, and alcoholism was fourth highest. HIV positivity was second, and having a criminal record for burglary was third. These are not uncommonly associated with substance misuse. Evidence is growing that substance use-related stigma impedes access to, engagement in, and retention in treatment and recovery support services, as well as self-efficacy for change. However, evidence concerning how stigma relates to recovery outcomes is somewhat mixed. Some research indicates that outcomes are worse when stigma is high. Others indicate that recovery outcomes can improve even though stigma may not change over time. Stigma experiences do seem to be more extreme when substance misuse is more severe. Public attitudes influence public policy. A U.S. public opinion study reported that 59% in the general public believe treatment for persons with drug addiction are ineffective, and 28% rejected the concept that a person with drug addiction could get well with treatment and return to productive life. These negative opinions potentially influence budgetary and other policy support for treatment and recovery services, as well as other policies affecting quality of life for individuals experiencing substance use disorder. Policies related to healthcare, employment, housing, child welfare, and criminal justice systems, for example. Thus, public stigma and structural stigma become intertwined phenomena. Low public support for policies addressing needs in this population also relates to other toxic stereotypes commonly held by members of the general public. Research identified perceptions that persons experiencing substance use disorder are potentially dangerous, unpredictable, are incapable of making their own decisions about treatment and other life decisions. To blame or being responsible for their substance-related problems and their treatment prognosis being doubtful. One aspect of public stigma that requires challenging occurs when individuals who may have engaged in substance use or misuse themselves fail to understand the difference between their own personal experiences and the experiences of persons whose substance misuse has become disordered. Urie Bronfenbrenner explained how, in the course of child development, the outside becomes the inside. In other words, explicit and implicit messages expressed by others become internalized and shape our self-concept. This internalization process is at the root of toxic self-stigma. Self-stigma results from internalizing stigmatizing beliefs and applying them to oneself. Considerable evidence demonstrates that individuals who experience substance use disorders are subject to a great deal of both public and self-stigma, which in turn is associated with lower self-esteem, higher depression and anxiety, and more sleep problems. Looking at the impact of toxic shame and self-stigma, consider this exchange with a woman preparing to re-enter the community after serving a sentence for drug-related offenses. She was literally, physically hanging her head in shame, blaming and berating herself for the mistakes she made with her children during the period when she was using drugs. asked a single question, "Do you learn from your mistakes?" She stopped and stared. She asked, "What do you mean?" The single question was repeated. "Do you learn from your mistakes?" After a long pause, while she considered the question, her whole posture straightened up. She lifted her head, looked the other person in the eye, nodded, and said, "Yes, I guess I do." That was all it took. She accepted responsibility for becoming a better mother. Blame and shame left her no solution for moving forward. She could not undo the past. Seeing herself as someone who learns from past mistakes showed her what she could do moving forward. The new outside message became the new inside. Blame and shame messaging damage a person's self-concept and self-identity. Shame and embarrassment over their substance misuse is frequently reported by individuals experiencing a substance use disorder. A majority of participants in one study reported believing that they have permanently screwed up their lives. They felt ashamed and felt out of place in the world as a result of their substance misuse. This experience promotes secrecy about their behavior and acts as a barrier to engaging with recovery support. A person who comes to believe themselves to be hopeless, helpless, unworthy, unlovable, bad, weak, lazy, useless, defective, and otherwise no good becomes boxed in by toxic self-blame, self-shame, self-doubt, and self-stigma. So how does this boxed-in person respond? They disappear, withdraw, escape, go away, and hide. This is not fruitful for engaging a person in substance-related change and recovery efforts. In fact, toxic self-stigma is one of the main reasons that individuals experiencing problems associated with substance misuse might avoid seeking health or mental health care, harm reduction services, and other recovery support. Unfortunately, there exists considerable evidence that feeling disparaged by others and experiencing external and internalized stigma have a deterrent effect on substance-related help seeking. Not only is this true in relation to substance misuse stigma, it's also true in relation to general help-seeking stigma. Unfortunately, many professionals with whom an individual might engage share some similar stigmatizing beliefs, along with mistrust and perceptions that the person who misuses substances is a difficult patient or client. Stigma involves discrediting an individual, labeling, stereotyping, discrimination, and imposing unequal power dynamics in professional interactions. Some may view it as a waste of time to provide services to an individual engaged in substance misuse or experiencing a substance use disorder, if they hold a belief that the situation or person cannot change, if they lack a belief that recovery does happen. Authors of a systematic literature review conducted in 2012 concluded that health professionals generally held negative attitudes towards individuals experiencing problems related to substance misuse, and that they had less regard for working with this population, lacked empathy towards them, and preferred that addiction specialists handle their care. A study comparing beliefs held by members of the general public, professionals, and clients in treatment for substance use disorders reported a couple of shared stereotypical beliefs: that these individuals are not trustworthy, tend to be aggressive, and are questionably able to maintain a regular job. More encouraging were results that indicated a high degree of agreement among professionals that someone experiencing addiction can be treated successfully, and that addiction is a disease, as well as disagreement that addiction is the consequence of weakness. Fortuitously, professionals having the most contact with members of this population held the most positive attitudes. Furthermore, education and training about substance misuse had positive impact on professionals' beliefs and attitudes. Compounding the picture, consider what happens when different stigma collide. The intersection or interplay among multiple stigmatized factors. For example, a systematic review of substance misuse literature concluded that ethnic minorities, youth, men, and those in military and health professions were disproportionately deterred by stigma from help seeking. Another review concluded that stigma-related barriers to substance misuse treatment were compounded for individuals who were older, a member of a racial or ethnic minority group, diagnosed with co-occurring depression, or tested positive for HIV infection, and that women faced additional stigmas, especially when pregnant, incarcerated, Black, or facing child custody concerns. An additional study demonstrated that among individuals experiencing unmet substance use treatment needs, women were more likely to report stigma as a barrier to treatment than men. And regardless of gender, parents reported the highest levels of stigma. Yet another study identified the stigma of addiction as a key theme influencing a lack of trust in the healthcare system, held by women seeking treatment. The intersectionality and stigma interplay related to the very high rate of trauma these women have experienced, in turn potentially affected their trust and formation of interpersonal relationships, which are fundamental to engaging in recovery support. And evidence abounds that individuals who identify as a gender or sexual minority underutilize treatment for substance-related concerns to an even greater extent than their peers, leading to treatment delay or avoidance that can contribute to more serious problems developing. Or, for example, consider the racialization evident in the interplay between opioid use disorder and race. This adapted diagram indicates that medicalization responses are more likely for members of the white race, and as stigma compound and increase for members of non-white races, criminalization responses are more likely. The confounding of racial and ethnic discrimination with stereotypes concerning criminality and substance use patterns has a very long history in the United States and in our policy responses. Another example of the interplay between different types of stigma is evident in literature concerning women who have experienced a substance use disorder and also been incarcerated. Not only are there typically fewer jail or prison-based substance misuse treatment services available for incarcerated women compared to incarcerated men, stigma surrounding substance misuse by women, especially mothers, is expensive and likely contributes to their being underserved. Considering intersectionality and stigma, criminal justice system sanctions and incarceration are disproportionately imposed on persons of color, a fact heavily shaped by the nation's war on drugs, a long-standing policy position which has been referred to as a war on Black women. In essence, race makes 4 strikes experienced by many incarcerated women. Let's turn our attention now to stigma as experienced by family members. All too often, families share an individual member's stigma. This is sometimes referred to as courtesy stigma or associative stigma. Family members may endure hearing other people talking in derogatory ways or making insensitive jokes about the person they love. Or they find that others diagnose them as being codependent or blaming them as enablers. Highly stigmatized labels, poorly supported by scientific evidence base. What we previously explored about an individual's toxic self-stigma extends to family members as well. They too may be subjected to a loss of respect, blame, shame, pity, criticism, unwelcome advice, or suspicion that they're in some way contaminated too. Extended family members may stress that it didn't come from our side of the family, or someone might expound, if it was my kid or partner or parent, I would ... fill in the blank, concluding with any number of hurtful statements. An Australian study concerning family members' experiences of stigma described how family members all too often were referred to in unsympathetic and derogatory ways, as possessing character defects and having codependent relationships that perpetuate or enable the person's substance misuse. Not only do family members experience public stigma, they assume aspects of self-stigma as well. In reaction, family members may become cut off from extended family and friends, engage in secrecy, and avoid contact with others who show a lack of knowledge and empathy and express judgmental attitudes. Participants in one study described the many ways they tried to avoid stigma situations and hide their family situation, thus extending the family's sense of isolation. They may hesitate to seek help because of their own experiences with toxic stigma. One family member described the experience as feeling like a pariah. Healthcare and service providers need to make themselves aware of the ways that family members experience explicit and implicit bias, or stigma, and how these experiences might affect families and family members' well-being and participation in supporting someone's recovery. Participants in 2 studies described the efforts and measures they took to moderate the effects of stigma. Efforts such as challenging misconceptions about substance misuse, challenging public stigma and stereotypes, and challenging the application of stigma to themselves and their family member. But this requires a great deal of knowledge, advocacy skill, support, and courage. Family members may even feel pressured to make difficult choices between the individual's well-being versus the well-being of the family as a whole. Ambivalence surrounding these difficult choices may make them seem inconsistent as they try to navigate a tortuous path between rocks and hard places. Also, in family members' response repertoire is being selectively open with others about the individual's and the family's situation, choosing with care who, when, and how others might be informed. Family members also may respond like individuals in treatment for or recovery from substance use disorders, and they disagree about disclosure to others. Disclosure may be forced on them for reasons of excused absences from school or work, or because their behavior compared to when they previously engaged in substance misuse is noted by others. Disclosure by pregnant women is a particularly sensitive concern. Reactions these individuals and family members experience may have a considerable impact on their psychological and behavioral outcomes, depending on whether the reactions reflect stigma or social support. Perceived or anticipated stigma is a major reason why individuals and family members avoid disclosure. As I explained at the start of every semester to students in my substance misuse course, they may not have permission from their family members to disclose information about their own or their family members' substance use. Self-disclosure is also family disclosure, so they need to be thoughtful about what they choose to disclose within the learning context. As a family member stated, there are some people you can talk with and some people you can't. So where do all these concerns about stigma leave us? Actually, we have available to us a realm of options for addressing substance-related stigma and its aftermath. First, we can enlist approaches for helping to change the person or family affected by stigma. Change the person or family interventions may be incorporated into most forms of evidence-supported and evidence-based treatment related to substance misuse concerns. For example, cognitive behavioral therapy interventions are designed to help change how a person interprets their experience as a means of helping them change their behavioral response, their response to those experiences. Likewise, with coping skills training, these are ideal venues for helping a person change self-stigma, their anticipation of stigma, how they perceive stigma for others, and how they respond when they do encounter it. Other therapeutic interventions may help individuals develop counter-narratives to the stigmatizing messages and stereotypes they encounter, or that they may have incorporated into self-stigma. An interesting study of individuals in recovery from alcohol use disorder identified a distinct difference in the personal narratives shared by individuals comfortably in recovery compared to those struggling in recovery. When their personal narratives contained elements of self-redemption, describing themselves as undergoing a positive personality change, the individuals were almost twice as likely to be comfortably in recovery compared to when their narratives were non-redemptive. It's unclear whether overcoming self-stigma and developing narratives that counter stigmatizing stereotypes may have a positive impact on recovery outcomes, or if it's the other way around. In a unique music therapy intervention study, engaging individuals in detoxification care to write blues music song lyrics, the lyrics that address stigma showed no statistically significant difference in participants' perceived stigma and social support. However, the therapeutic use of songwriting offered a creative clinical opportunity for individuals to explore stigma and the impact of stigma and social support in their lives. We paid attention to language use in the first part of this presentation. Changing the environment and culture related to substance misuse can begin with efforts to address stigmatizing language use ourselves and whether we might encounter it personally and professionally. For example, since about 2013, professional journal editors and professional organizations have begun advocating for non-stigmatizing language use related to substance, including in our clinical records, charting practices, and other forms of communication. The White House Office on National Drug Control Policy, or ONDCP, published a 2017 memorandum advocating for a shift in all federal departments and agencies to promote use of non-stigmatizing substance-related language. So just how do we practice these behaviors? What does that look like? We begin with using person-first language. This means starting with words designating personhood. Words like person, individual, man, woman, child, adolescent, or adult. Qualifiers come after the person-first description and describe the person's experience or behavior. For example, a person who engages in injection drug use is preferable to labeling them as a drug injector. And a person experiencing a substance use disorder is preferable to labeling them as an addict. Other examples of person-first language might be an adolescent engaged in substance misuse, a man experiencing alcohol use disorder, or a woman in recovery. Person-first language conveys respect and emphasizes dignity and respect by defining someone as a person, regardless of whatever else is involved. They are first and foremost still a person. So just to test yourself, how might you respond to hearing the label child of alcoholic or children of alcoholics? How might you revise use of that label in a non-stigmatizing way? How about describing someone as a child with a parent experiencing alcohol use disorder? Fortunately, we have access to some great resources to help us monitor evolving trends in substance-related language use. For example, the Dictionary, assembled by the Recovery Research Institute, provides a glossary of substance-related terminology. Not only does the dictionary provide descriptions of frequently encountered terms, it presents stigma alerts where relevant and explains why using a certain term might be problematic. The National Institute on Drug Abuse published a handout about reducing stigma through more thoughtful use of language related to substance misuse. Not only does it identify potentially stigmatizing terms, it offers alternatives and explains the rationale behind the recommended changes. For example, the handout explains non-stigmatizing alternatives to the term addicted baby, such as a baby with signs of neonatal withdrawal syndrome, person first, and clinically accurate language. It is worth noting that many clinicians are shifting away from the term neonatal abstinence syndrome to the term neonatal withdrawal, neonatal abstinence syndrome to the term neonatal withdrawal syndrome because of the stigmatizing behavioral connotations associated with the term abstinence and greater clinical accuracy of the term withdrawal syndrome. Let's focus for a moment on a few other potentially problematic terms, starting with the word habit. Dictionary synonyms for habit include inclination, proclivity, tendency, and even groove. The word habit suggests that a person could just stop using alcohol or other psychoactive substances if they were so inclined or simply chose to do so. A word like habit soft pedals the difficulty of overcoming powerful and compelling neurobiological, psychological, social context, and physical environment forces acting on a person's substance misuse or substance use disorder. This word habit undermines the seriousness and severity of substance use disorders and the effort involved in change attempts and recovery. Another consideration relates to describing a person's drug test results. Clean and dirty are, by extension, describing the person, not just the test result. Instead, using medical terminology that describes the test, not the person, is what we're after. The test was either negative or positive for substances. This shift in language fits into a paradigm where we move away from and discourage applying a moral failure lens to substance misuse and replace it with an understanding of the underlying biopsychosocial forces at play. At a policy level, this translates into moving away from punitive and criminal justice responses and promoting treatment, harm reduction, and recovery support responses. Consider terms encountered by family members of a person experiencing substance use disorder. The dictionary places a stigma alert on the words codependency, explaining that it tends to pathologize a family member's concern and care about a person engaged in substance misuse. A label like codependent provokes shame and blame. The term also tends to ignore the reality that a family member actually may be physically, economically, legally, or otherwise situationally reliant on that person. For similar reasons, the term enabling is accompanied by a stigma alert in the dictionary. The term infers blame on the family members for making an individual's condition worse by interrupting naturally occurring negative consequences of their substance misuse behavior. This concept ignores and pathologizes much of what we know about family systems, which is a whole different presentation topic. In short, we can begin helping to reduce the experience of stigma for individuals and families with our own careful use of language. And we can have an impact on the broader culture when we advocate for change in how others use language as well. As an extension of our challenging the use of stigmatizing language, We can all work to challenge public stigma by challenging all sorts of messaging and media portrayals that contribute to substance-related stigma and stereotypes. On the topic of changing culture through professional education, a team in Canada tested a comprehensive set of tools for providers to reduce stigma. Training workshops that integrate these resources contributed to professionals' increased awareness of stigma, their greater comfort in discussing harm reduction and substance use with clients and patients, and increased their awareness of organizational strategies to reduce stigma. The team concluded that providers are motivated to engage in best practices when they're prepared to do so. For example, one organizational or institutional change strategy relates to promoting the use of non-stigmatizing language in professional communications, records, and charting practices. Along with continuing education efforts, stigma, stereotypes, and attitudes need to be addressed in pre-service education as well. Evidence indicates that social work, nursing, medical, and other professional students come to training with beliefs, stereotypes, and attitudes about individuals who engage in substance misuse, their families, and their prospects for treatment and recovery, beliefs and stereotypes that may need to be unlearned. As an interesting addition, professionals providing services to a stigmatized population also may experience associative stigma in much the same way we saw that family members might. This associative stigma may contribute to professionals' experiences of burnout and low job satisfaction. Fortunately, this phenomenon of perceived or experienced associative stigma appears to be relatively uncommon among professionals. So, third in our list of options is influencing the ways that individuals interact with their environment. We've looked at a few change the person strategies and some with the potential for changing the social environment. Let's look at addressing the interplay between person and environment. Therapeutic citizenship is a model that both changes individuals and changes environments. Therapeutic citizenship is essentially about becoming an advocate for change, serving as a representative of a stigmatized group who can challenge stereotypical and stigmatizing beliefs and attitudes from the strength of a positive example. Therapeutic citizenship, on one hand, can offer an individual a sort of redemption from their prior spoiled identity, replacing it with a valorized social identity and restoring self-esteem. Engaging in therapeutic citizenship as advocates and change agents helps internalize a recovery identity, supports reframing and reconceptualizing the past as a source of empowerment and meaning, and provides social networking opportunities within a recovery support community. Some recovery programs emphasize altruism and service, and within a stages of change model, this type of activity is often associated with recovery maintenance. Thus, engaging in public advocacy and efforts to create more responsive recovery support systems for others has potential therapeutic value for individuals, and at the same time helps change environments on their own and others' behalf. As a caution, individuals in one study identified as potential harms that they may set themselves up to experience additional stigma and discrimination, that advocacy activities may interfere with their ability to engage in self-care, and that the benefits may not outweigh the personal cost or harm. The MARS project, which stands for Medication Assisted Recovery Services, is another example of how therapeutic citizenship promotes change in both individuals and the social context. Sponsored by the National Alliance for Medication Assisted Recovery, the peer-initiated, peer-based MARS project delivers education to dispel stigma concerning buprenorphine and methadone treatment with the aim of improving treatment outcome. MARS sponsors recovery support groups substance-free and social activities, recovery celebratory events, and peer leader training. The organization hosts training and a certification exam for individuals to become certified as medication-assisted treatment advocates and engaged a peer council to help direct the project. Together with other groups, NAMA Recovery sponsored a group called Stop Stigma Now, working to create a focused national public relations and marketing campaign for educating professionals, policymakers, families, the criminal justice system, and the general public about the medications to treat addiction with the goal of ending the pervasive social stigma surrounding medication-assisted treatment. Aside from the plentiful evidence that peer recovery support can have a significant positive impact on an individual's recovery outcomes, consider the potential of exposure to individuals who are flourishing as a means of challenging prevailing public, professional, and self-stigmatizing stereotypes about persons who have experienced substance use disorder. Stereotypes and prejudicial responses that we might challenge in this way include recklessness, unreliability, inadequacy, and threat stereotypes. Peer counselors can present alternative images, the opposite to each of these stereotypes, and can draw a very different response set, replacing responses of anger, pity, and dread with respect. They portray substance use disorders as treatable and reinforce the message that recovery happens. Evidence exists that portraying substance use disorders as treatable can improve public attitudes and reduce stigma related to substance misuse. Investigators in one study concluded that portrayal of persons with successfully treated substance use disorders is a promising strategy for reducing stigma and discrimination, as well as improving public perceptions of treatment effectiveness, which in turn may influence policy favoring recovery support services. So, what did we address in this presentation? That stigma is a common experience for individuals engaged in substance misuse, treatment, and recovery, as well as for their families. That the experience of public, professional, and self-stigma negatively impacts help-seeking and recovery efforts. That the language we use can be stigmatizing. We advocate for non-stigmatizing language use, and when we slip up in practicing these new skills, we need to practice forgiveness and learn from our mistakes. We identified strategies and resources for addressing stigma and reducing its negative impact, promoting change with individuals, their family, communities, organizations, institutions, and policies. As professionals and concerned community members, from our very first outreach and engagement encounters, through screening, assessment, treatment intervention, recovery support, prevention interventions, and even our policies and practice environments, it's important to consider not only how we might inadvertently communicate stigma about substance misuse and people experiencing substance use disorders, but also our responsibility to advocate for and respect their inherent dignity. Recommended actions we each can take include educating others in the general public and among professionals about substance misuse, evidence-supported treatment, that treatment works and recovery does happen, and about stigma. We can use language with care and communicate the personhood of individuals who engage in substance misuse and their family members, and respect their inherent dignity and personhood. In the language of recovery support, the message is that I am still a person. So I'm clicking through the reference slides rather quickly. If you need to see details, feel free to use the pause button. and I thank you for your interest and attention to this presentation.